And we are going to take a deeper dive now into biomarker testing, certainly something Dr. Lee spoke about, but we're going to hear now from Erin Eller, who's going to talk specifically about biomarker testing's role in personalized healthcare. And Erin has held a number of roles centered on cancer diagnostics over the past 12 years. And currently, he is a member of Genentech's biomarker testing team, where he works directly with healthcare professionals such as pathologists, oncologists, surgeons, navigators, payers, and advocacy groups. So it's my pleasure to now turn it over to Erin.
Thank you, guys. And thank you, Dr. Lee. I tell you what, that is a very hard act to follow. But I'm going to try to do my best to do that and provide some education and hopefully inform here. I think what I found about Dr. Lee's presentation so impactful that kind of segues nicely into what we're about to talk about is just how busy the space is. How busy the space is. It's just such a moving target every day. Staying ahead of it, staying on top of it is so critical, and it's sometimes a challenge to do, and hopefully that's a little bit. I'll explain in a second what our team does to kind of help provide some of those updates. So again, thank you to LCI for this opportunity to speak to such an important group of individuals, and thank you again, Dr. Lee, for such a great, impactful presentation and the good questions that came in. Today, I'd like to talk about biomarker testing and the role that it plays in personalized healthcare. And I think it will kind of segue nicely into what Dr. Lee spoke about. But before I do that, just to kind of level set with everybody, I do work for a company by the name of Genentech, who specializes in development of targeted therapies. And about 12 years ago, our team realized, the biomarker testing team that I'm part of, realized that with such a busy area and market and space, that we were finding that a lot of patients were getting missed as far as being scored and being diagnosed. And so what we found is we could, as a team, go out and educate and support and better understand what are those challenges with the healthcare professionals that they are having in order to help identify patients for these targeted therapies as it relates to biomarker testing. And so our team motto is simply to make sure that every patient has an opportunity for an accurate and timely diagnosis. And that being said, we're finding that in our conversations that there are a lot of challenges when we're talking to healthcare professionals as far as identifying these patients. And so today, again, I'm going to focus on biomarker testing and tie it into personalized healthcare in a meaningful way that hopefully shows how it ties to the triple aim and the reduction of healthcare cost, improving patient experience and outcomes. If you could go to the next slide. So what is PHC, or personalized healthcare? And I often joke about this in a way that I think if you ask 10 different people what their definition of PHC is, you're probably going to get 9 or 10 different answers. But for the purpose of this conversation and presentation, it's personalized healthcare is using data and technology to tailor and optimize care for individual patients. And so for what we're going to do today is our commitment as an organization and as this team is to do our part around biomarker testing to improve what we're calling the triple aim, to improve healthcare, to lower cost, and to better care, to learn from every patient and to help provide and identify. Next slide, please. So what is biomarker testing? I'd just like to share a real quick video that we've created to inform and empower those patients and let them know what biomarker testing is. I think if you there we go.
Receiving a cancer diagnosis can leave you feeling uncertain, overwhelmed, and confused as to how you should move forward. But now, with biomarker testing, you have a way forward. Biomarker testing may offer insights to why and how your cancer is unique, which may help you and your doctor find the right treatment plan that fits your unique needs. So you have a path forward. Talk to your doctor about biomarker testing today.
Thank you. Thank you. So let's talk a little bit about that. Let's talk about biomarker testing and the role that it plays in personalized healthcare. If you look at this top chevron at the top, it's a busy slide and it's a busy kind of area at the very top. But when we think about personalized healthcare, and we also think about the journeys of each of your patients, it often starts with screening and helping identify, diagnosing that also drives treatment selection, monitoring, remission, and long-term outcomes, and also helps inform for clinical trials. For the purpose of this presentation, I would like to focus on the diagnosis side of this and how that relates to biomarker testing. Again, I think Dr. Lee did a really nice job talking about just how busy a space this is and how it changes, it seems like, every single day. So let's look at the bottom and going from left to right. How busy space is it? We found that in 2017, biomarkers accounted for $11 billion worth of business and that are associated with that. Fast forward to 2022 with a projection of $20 billion. So we need to do our role in helping from a PHC perspective, reducing that cost. Biomarkers and the evolution of single and broad panel testing and the applications that are associated with this in oncology. If we look at the middle here, and we're talking about the FDA approvals, again, Dr. Lee talked very nicely about that. You're seeing such a growth in those biomarkers as they are tied to these new FDA approvals over the years. And I think it's fair to say that this is not going to change. It will likely only increase. So it's important to recognize of identifying that biomarker in those mutations in order to drive and understand treatment decisions for those targeted therapies that are available. Also, Dr. Lee specializes and talked quite nicely about clinical trials. A lot of the tests and a lot of the diagnosis process also helps form and identify those individuals that may not have a current targeted therapy, but also inform the availability of clinical trials. Next slide, please. Again, a super busy slide. And I think what you're seeing here is, yes, we're talking about lung cancer today, but biomarkers also play a critical role in other disease states that's represented by this slide. I think the other thing to point out with this is, as fast as we were able to put this slide together and present over the last few months, if you will, this slide is already outdated. There are already new FDA approvals that are not on this slide. There are new biomarkers associated to help identify those targeted therapies that may not also be in these slides. So it is just a very busy space. I will not go into technically here, but if you're looking at the bottom, these are the different types of diagnostic testing methodologies in which you can help achieve those answers to identify those mutations. Things like IHC for PD-L1 testing on the far right side, FISH, PCR, and we'll spend a little bit time today going into a little bit deeper around next generation sequencing, or NGS. But there are a number of different testing methodologies. The point here is to achieve those answers. Next slide, please. So NCCN Guidelines, or the National Comprehensive Cancer Network, is what NCCN stands for. Is kind of the Bible, if you will, or the go-to reference for clinicians in order to provide those updates around guidelines to help inform for treatment decisions. So NCCN does support the use of next generation broad panel molecular testing in order to achieve those results. They also support and suggest that at a minimum, the 7 must-test genes should be considered in trying to be identified to get answers. When we're looking at these two scenarios, A and B, what we're trying to represent here is there are a number of different ways to ultimately achieve those answers. On the left-hand side, and I mentioned earlier, the different testing methodologies that you could use, PCR, IHC, and IHC, for PD-L1 and EGFR, those are individual tests that often may require more tissue. You may be taking a shot on goal to find those answers out, and maybe a little bit more complex, could potentially drive up cost by doing it. Doesn't make those wrong methodologies. It's just something to consider. For example, when you have a small amount of tissue, limited time in order to get those answers back, maybe you should consider the scenario B that's represented on the right-hand side. Again, the same mutations you're trying to get answers for, just a different type of technology and methodology in order to get those answers. So on the right-hand side, it's just a different approach to it. IHC in order to find your PD-L1 immune therapy answers to drive treatment decisions for that. And then the use of broad panel testing in order to get using one test in order to get all the different answers that you see on the left-hand side. So in comparison, multi methodologies on the left-hand side to get the same answers versus one particular methodology, next generation sequencing, to get the same grouping of answers here. So just two different approaches. And what we're going to dig into next is what are those ramifications and considerations and how they apply to personalized healthcare and the reduction of that triple aim triangle that I showed. Next slide, please. So again, we talked about the triple aim. On the left-hand side, oncologists and treating clinicians and those healthcare professionals have a lot going on. And these trends are changing every single day that are representing on the left-hand side. And so it's important to understand, how does the triple aim play into that? How can we do our part as an organization and as a group to reduce that cost and apply the triple aim to that? We're going to talk a little bit about possibly how next generation sequencing applies to helping reduce and do our part from a triple aim perspective. Next slide, please. So again, digging into that, so better care, better outcomes, and reduction of costs. I'm not going to go through each one of these, but I would like to just kind of highlight what does that mean and how does that apply when we're talking about biomarker testing. So we're talking about better care. One example is in a survey, there were 340 lung cancer survivors that had to rebiopsy, and 22% of those patients experienced complication following biopsy. So it can be an aggressive procedure in order to try to do that. So you would like to try one time to go in, resect and get that specimen, blood and or solid tumor, as Dr. Lee suggested. And it's very an invasive procedure. Should you want to do that procedure, acquire that specimen, and make the most out of that specimen and get that answer? And often we find that's often what our team is often talking about, is there are complications with minimal amount of tissue, not enough tumor content in that tissue to achieve the answers. So how can we apply the guidelines to help improve that better care? As far as better outcomes go, the consideration of NGS results also informs in clinical trials. NGS and taking that consideration as a methodology to produce better outcomes. Again, small specimen, considering you've got maybe one shot to get that answer, what testing methodologies are being used to get you those answers and not use that tissue up in an effective way. So the reduction of cost, again, we'll go through a couple of examples here when we're talking about the reduction of cost. But it should be considered, are we spending more money? Are labs, are health systems spending more money in doing single gene testing to get the same answer that potentially next generation sequencing or broad molecular panel testing could do in one particular round of opportunity to get those answers? Next slide, please. So again, we mentioned a little bit about this, about how can we improve the overall patient experience in biomarker testing. And there are a number of different studies that we'll review here in a second that will talk about that. One I thought that was very interesting is that 340 lung cancer survivors, 231 patients who had a biopsy at the time of diagnosis, 42% of them reported that they experienced a painful one, and 22% of those experienced complications. Again, the procedure, making sure that you're acquiring that specimen in order to get that answer is critical. Next slide, please. I really like this slide. This is, again, a very busy slide, but what we're trying to show here is the importance of doing broad molecular panel testing potentially to get those biomarker mutation answers to drive treatment decisions. In this particular study, it talks about the overall survival rate if you're able to appropriately identify those mutations to drive treatment decisions for targeted therapy. In this particular study, those who had the biomarker testing appropriately done and identified those those mutations to drive targeted therapy versus those who did not and were unable to identify those driver mutations, often going just on chemo. When you look at those two comparisons, you're looking at an overall survival median rate of roughly, I believe, around 19 months. So there is a critical advantage as far as overall survival rate in making sure that you do identify those mutations for biomarker testing upfront to help drive those treatment decisions. Next slide, please. I think this does a nice job on the widget of triple aim. It's both not just outcomes, but also it shows an example of how appropriate biomarker testing can improve and reduce costs. This comparison we're looking at here at the progression-free survival rate and the cost reduction. And I'll pause here and just say that one of the things that often a misnomer that goes around is broad molecular panel testing or next generation sequencing is often more expensive than single point mutational testing. In this particular trial and paper that was written, it compared the standard care where cancer was diagnosed up front. They did not, maybe they went through single point mutational testing and not that broad comprehensive panel testing. And they went on a standard treatment here. That was a 12-week progression-free survival rate. And the study showed about a $5,000 cost per week per progression-free survival week here. If you're looking at the bottom here of really what good looks like, in my opinion, and you're taking that precision medicine or a personalized healthcare approach to it, and you're seeing that these healthcare professionals are having conversations in a molecular tumor board, discussing what their testing protocol is going to be, making sure that those protocols are in place to do that molecular testing, reviewing that, staying up to date with that, and getting those answers for those mutations in order to drive those therapeutic decisions. Those two compared in this study show roughly almost a 12-week progression-free survival and actually a reduction of cost. So this represents, I think, nicely the importance of that communication among that multidisciplinary team in order to understand what they're going to do from a molecular testing standpoint, have answers for those situations where it's difficult to provide accurate and quality sample specimens, and they're on top of that. The importance of that is shown in this particular study. Next slide, please. So in this particular slide, again, very busy slide, but it is an important one. And I want to justify, we're talking about from a payer standpoint and how can our organization and team do our part in reducing costs. I think when you're looking at biomarker testing, just to define this particular study, next generation sequencing, or NGS, on the bottom left-hand side is defined by a number of mutations that are listed here and trying to get that answer with one particular molecular test, for example, using next generation sequencing. Exclusionary testing, or taking shots on goal one at a time. For example, in this one, we're talking about KRAS testing. While it was negative, then they decided they had to move forward and do other molecular. So we're using tissue, we're spending cost of testing in order to try to find those answers. There's also the option of sequential single gene testing. In scenario A previously, that was talking about different testing methodologies, one by one, trying to get those biomarker answers, and the driving of cost, the impact of turnaround time, waiting for those results, and not having the answers to drive treatment. And then there's what's referred to as hotspot panel testing. And that is basically a determined group of genes in a particular testing panel that they're looking for here that may not include all the relative must-test important genes in that particular one. So those are the definitions of what we're looking at now on the right-hand side. So when we looked in this particular, they looked in this particular study of Medicare versus commercially insured patients, in comparing the cost of these different approaches and types of test methodologies to get answers for biomarkers, we saw that if you do broad molecular panel testing like next generation sequencing upfront, there is a reduction in cost as compared to the other ways to achieve those same answers. So it is important to do that part from a triple aim perspective and personalized healthcare around biomarker testing, to have that can take that consideration around doing broad molecular panel testing like NGS upfront. And I think it's also important here to point out, I often get, when I'm meeting initially with healthcare professionals, I think naturally they're very used to sales individuals that are trying to sell a particular test or represent a particular national reference labs that conduct these tests. I think the uniqueness of our team and what we're doing is, frankly, it does not matter to us. We do not sell testing. I am not trying to acquire business from a testing standpoint from any of these customers. It doesn't matter to us where it is sent, as long as the appropriate testing is done. I often simply say my agenda at the end of the day in talking with customers and educating and informing, my agenda is very simple, and it is the patient. That simple, the patient. Next slide. Next slide. I'd taken that. So I just want to close by saying thank you. I want to thank you for this opportunity. I want to thank the healthcare professionals that are on this particular call. You have a very, very difficult job. And I hope our team and others support you in helping inform and do that. To the survivors, to the patients, to those caregivers, you guys are what I wake up for every single day. With you guys in mind, I would encourage you, continue to fight. Do not give up. Stay informed. Be empowered. Lean on individuals and organizations like Lung Cancer Initiative of North Carolina. They have incredible literature and pieces for patients, biomarker testing, and other things. I would encourage you to look at that and lean on that and other resources. So again, thank you for the opportunity.
Aaron, thank you so much. And thanks for playing a really important piece of us keeping up with all of this information and trying to stay informed and do all of those things. We have a few questions that I would love to ask you before we wrap up here.
Sure.
First, one person was wondering, is the next generation sequencing now the standard of care for lung cancer treatment?
Yeah, Dr. Lee, feel free to weigh in. I'm glad you're still on the line here. Standard of care, I would rephrase it. I would say that the NCCN that I mentioned previously, and they produce guidelines, which are often and most often used by healthcare professionals to make treatment decisions. They absolutely support and recommend the use of next generation sequencing or broad molecular panel testing as a preferred method to achieve those results, those molecular mutation results. Yes. And Dr. Lee, feel free to weigh in if you.
Yeah, it is a little tricky. There's a little bit more nuance to it that I'm sure you know, but it really is in the NCCN guidelines for across the board in the adenocarcinoma variants, squamous cell, and as I mentioned in my talk, in the younger patients, never former light smokers. Outside of those two spaces, I push the envelope oftentimes and get it in some other maybe less conventional, less guideline supported settings, which worries me a little bit because I don't want patients to ever be in the position of having to pay for something, if there's not a guideline to support it. The companies that do these sorts of tests are incredibly facile at submitting appeals on patients' behalf. I have ordered so many of these panels, and I feel like I would know if patients were getting bills that were out of, that were unexpected or unrealistic to pay. And I never hear that. So I push the envelope. I do not get next gen sequencing in small cell lung cancer patients really much at all. We don't have a lot of targets in that space yet.
Yeah. Yeah. And I would just say, to piggyback on that, not speaking for any particular national reference lab or health system that is doing this, but I would encourage you, often they do provide patient assistance. I'm not guaranteeing it. I'm not implying that. But I would encourage you to stay informed. I would empower you to ask questions from your providers and your payers to better understand that. And share your voice. It is not easy. It is not one particular payer has the same policy as the next. They're very different, but feel empowered to ask those questions. Seek out if there is those financial assistance options out there, because many try to help and recognize that those are going to be real situations that are going to come about.
Absolutely. Thank you very much. Another question from a couple people. Why does Medicare testing cost more than commercial insurance? I know there was a comparative graph on one of your slides.
Yeah, and so that was a study. I'll give you my opinion on that. I think when you're looking at, it's looking at the aggregate number in that particular study. It's looking at the commercial payers, the different policies, the different reimbursement rates versus Medicare, where it's a probably straight line number that they reimburse for, if you will. So commercial payers, different policies, Medicare, a straight fee often. And I think in that patient population in this study could have adjusted that. But a good question, and I get it often when I present that slide.
Okay, great, thank you. This also might be a more complicated question. I don't know that you totally have the answer to, but you mentioned the total cost of care for next generation sequencing being lower than other methods of biomarker testing. What is included in the total cost of care?
Again, really, really good question, and it's a pretty complex answer, but in the simplest forms, I'll try to answer. When that particular study in comparison, what we're looking at, that total cost of care is the procedure. We're looking for often when we're looking at the single point mutation test as an example that we gave, I believe in scenario A. What that's showing is maybe they try to just get PD-L1 and EGF, and I'm making these scenarios up, PD-L1 and EGFR answer upfront. They don't get an answer. So they go back and either rebiopsy or use additional tissue and send out. Meanwhile, turnaround time, getting those answers back, treatment decisions are being often delayed. Additional tests, almost kind of taking 10 shots on goal to try to see that answer. Versus I often describe next generation sequencing as if you've got one shot with a small amount of specimen to get all those answers, often broad molecular panel testing can do that. So it's just a different approach that's taken in consideration the procedure, the multiple times of trying to get answers for those different single genes tests versus one particular shot on goal, for example, with next generation sequencing. Again, I will give my opinion on this. Next generation sequencing is not going away, is my personal opinion. It is kind of here to say it's only going to evolve. Dr. Lee, again, I refer to, it's not in our slide, but even liquid biopsy, for example, is another way that is just shows and represents growth and not giving up on that patient. For example, solid tumor, I believe, would still be the gold standard is trying to achieve that answer. Liquid biopsy, whether it be in parallel or afterwards, I think can also inform if it's positive. But if it's negative and you're doing, for example, liquid biopsy up front, you should not give up on that patient. You should try to achieve those answers. So it just is another more thorough way to get those answers. So it is evolving, and I don't think it's going away anytime soon.
That's great. Well, thanks. Yeah. And so we'll continue learning and hearing from you guys as all of these technologies continue to evolve. So those are all of our questions. Erin, thank you so much for your time and logging on this morning. It was great to hear from you.